Okay, thanks for coming back. We're in the last session. Thank you to the speakers that went before. It was really helpful to see some of the other processes in research. We do have quite a fragmented research ethics system, so it's good to have those different processes in the room to understand, what you have to go through as researchers, and we're always trying to reduce the duplication. I think we're going to work with the Health Research Council to try and align our new application forms as much as possible with the funding forms, so the copy-pasting efforts that we see might work a little bit better than they currently do. So I've got a few things to go through in terms of concepts, I suppose, that may have changed in the new standards. So I'm going to kick off with informed consent, which is kind of a special interest of mine. Informed consent is quite a well-trodden path in research ethics. It's kind of the cornerstone of what research ethics is. In New Zealand, it relates to the concept of mana, or personal autonomy, which is the person's right to participate in research, their right to be appropriately informed of the risks of harm to themselves or their collective, through clearly explaining the requirements. So it's a way of discharging your obligation to respect that person. Obtaining informed and voluntary consent of participants is still the default starting point in both the standards as well as in New Zealand. So the general features of informed consent, that it is dynamic, so it's an ongoing process, it's a relationship. Voluntary and informed are the two keystones of informed consent. However, I'm more interested in modifying the consent process, and this is effectively all brand new guidance in the NEAC standards, and it can get pretty complicated pretty quickly, whether that's for legal reasons or ethical reasons. So just some of the things that we've provided guidance on. Electronic consent, so looking towards more remote consent examples. Looking at different mediums to seek informed consent, I think that electronic consent presents a real opportunity to have potential participants understand information a lot more clearly. We can be novel with regards to using video. You can quiz for informed consent so that key aspects of the study are understood, particularly if you're moving towards more remote consenting where you're not necessarily face-to-face with the researcher. So looking at some of the things that we want to see with electronic consent, and it is starting to become more common. So trying to stay ahead of the game with these new technologies. Withholding information and deception, I'm not going to go into this too in depth, but effectively looking at some of the considerations around blinded trials, but also active deception. These health research standards apply to all health and disability research, and one of the key areas through the public consultation was recognising some of the social research that does use deception potentially in order to achieve its study aims. A lot of people here have a clinical hat on, so deception isn't really part and parcel of anything that we do in those contexts, but that's why the guidance has to be broad enough to apply to a lot of these other health-related contexts as well. Integrated consent is something I'm going to be talking about in a bit more detail. Abbreviated consent has been acknowledged as acute consent in emergency contexts. One of the challenges I think that researchers face is that balance between providing information in an emergency context and balancing their treatment in those contexts. So we provide some guidance on what consent looks like under acute circumstances. Opt-out consent is another one that has hit a bit of a legal barrier that I'll talk about, but opt-out consent typically was born out of registries. So registries would provide information perhaps in a clinical discussion and you were given that and perhaps given a phone call as well. If you did an opt-out, your information would be in that registry. There's quite a bit of research around looking at what the cost of consent is compared to opt-out consent in registries. Obviously, there's a tension there between respecting people but having as many people in the registry as possible. And opt-out does vastly increase the amount of data that goes into these registries. So is that a matter of people not caring so much, or is it that they're not actually having a meaningful chance to opt out? So we've provided some guidance on what that might look like, but currently it does not necessarily meet the legal requirement for informed consent in New Zealand, and we'll talk about that in a moment. Waivers. So our national ethics committees, our health and disability ethics committees, have an important responsibility. They have the ability to waive consent for use of identifiable data or identifiable human tissue for health research. So that's a big responsibility, and there has been guidance before on some of the things that they should consider if they're going to grant such a waiver, but we've strengthened it, so I'll explain the things that we've added to that to make it more of a robust process to seek a waiver. Consent for future use of health data in human tissue. So one of the big challenges that we face is sending samples overseas and biobanking. In 2012, when the Health and Disability Ethics Committee standard operating procedures were updated, they added Chapter 13, which was on the requirement for all biobanks to be registered with an HDEC. This, I think, was kind of thrown in last minute. There wasn't ever really a plan to figure out how we would do that. Over the last 5 years, we've been getting more and more biobanks to register with HDEC, so we're getting more oversight of the use of human tissue in New Zealand. But if you look at what the definition is of a biobank, it's the storage beyond the duration of a particular study of any samples and their associated data. So technically, there are probably a lot of biobanks. We often get told of freezers in people's cupboards, and you don't want to tell me those kinds of things. But we're trying to get a handle on that, because it's really important when you start to move away from consent at all. The corresponding need is to have really strong governance, really strong ethical oversight, and particularly with biobanks, we're actually looking at that idea of dynamic consent quite a lot. So reconsenting for each use, building relationships with the people who have their tissue in those banks. Where we lose the ability to do that is when we're looking at international biobanking. So that's something we can talk about as well. Lastly, again, one of my areas of expertise is research with adults who cannot provide informed consent. So we've provided a lot more guidance on effectively the best process within the current restrictions of the law, and NEAC took a strong view on effectively stating that the current law is not fit for purpose. So that's an ongoing discussion with the Health and Disability Commission. So, so one of the challenges, how can you modify informed consent while maintaining respect for people, their mana, and keeping within the law? And can consent be simplified? So here I wanted to ask the researchers in the room, what challenges do you face with informed consent, and do you think that the current consenting processes for health research in New Zealand are achieving the goal of informed consent? And again, you're not going to get in trouble if you're saying you're not getting real informed consent. I think it's a myth, to be honest. Yeah.
Well, I think the informed consent of adults has to be, I think even the new standards, it's still completely opaque.
In terms of the process of how that supported decision-making looks? Yeah, so one example as a result of the standards being published is work that's ongoing with a working group with a number of other government agencies as well in the context of what it looks like to support children in making their own decisions. So it is, never say this word in the afternoon, putting into effect the standards and some procedure to understand what it looks like actually for real researcher guidance. We expect that to be developed with the necessary experts. So the standards can't go into too much detail. They can recognise that a supported decision-making process, say with someone with mild dementia, is acceptable, and create a kind of cultural shift where we are more comfortable with consent looking different, but they can't solve exactly how to do that quite particular thing. Yeah.
I think also, this is Hannah, you're right.
Absolutely, and that's one of the big things that we want to achieve, particularly based on the type of research and the risk of the research, is to have a much shorter, more accessible research documentation. One of the things that I think is a difficulty for ethics committees is when they're looking at an application and they know that informed consent is going to take place. The only thing that they can really have control over in terms of those future informed consent procedures is the written information. But in reality, it's a lot more important, that relationship between the person that's seeking consent and the relationship with the potential participant. And I've heard this, again, I hear some strange stuff, but I've heard a researcher say, it doesn't matter what's on the form, they love me, and I'll get them in the study, and and that may be a good thing because he's very personable and understands how to communicate, but depending on the context and where you hear that, you might have some alarm bells. But that's something that we can't really see. And again, the standards, they recognise that the relationship is really the most important thing, and I think that we just need to curtail applying the same complexity and detail that we do for, say, big pharma international trials to a lot of this, lower risk research, particularly if we're going to encourage investigators in New Zealand to do investigator-led research and research that's actually relevant for our communities. So I think that that's a step that we're going to have to take together in terms of figuring out what exactly that looks like. One of the key areas where this might be relevant is comparative effectiveness research. So I'm not sure whether people are aware of what that is, but effectively it's a randomised controlled trial, but all of the treatments are in routine care. So the research elements in this kind of clinical trial are not the treatments themselves. Rather, it's adding randomisation, sometimes at a group level, sometimes at an individual level, to generate real-world evidence on whether these standards of care work in comparison to each other. They're very pragmatic, so more or less everyone is in. They try and reflect a clinical context or a routine care provision context, possibly also happening in more frontline health areas such as in GP offices. So one of the kind of international criticisms is that traditional informed consent processes are a barrier and poorly suit these low-risk clinical trials. So they are the study type that's getting the most attention to looking at simplified or integrated consent. So this is something that we think we can work with within the law. Fortunately, the Code of Rights, it gives you this kind of legal concept of a reasonable person, which I've never met ever, but we must follow this reasonable person. And it says they'd want to know what a reasonable person would want to know. So that means that I think that there is, probably a strong case for having these more simple consent forms or consent procedures that may even be verbal. Again, looking at Māori and their preference often for verbal discussions, verbal consent. Currently the code requires consent for research to be in writing. So this is again a barrier for being flexible with regards to having these more either novel or culturally appropriate consent procedures. But what would it look like? Well, it's obviously going to be substantially briefer for practical reasons than what you might ordinarily see. Again, we're looking at it occurring in a clinical discussion. So one of the big challenges that we're seeing is research and treatment used to be always distinct, and in particular morally distinct. We had a research ethics framework and a clinical ethics framework. It's why we get so involved around conflict of interest and dual role, whereas now we're moving both of them together, and we need a new ethical framework when we're combining treatment and research more commonly. So this is going to impact consent, it's going to impact the conflict of interest. We're going to have to upskill our clinical workforce to be research literate. And what this is going to do, though, is it is also going to increase the research literacy of patients if it's becoming more and more common in the healthcare system. So what might it look like? Oh no, didn't update those slides. So we're thinking no longer than 5 pages, ideally 2. It should have enough information for people to decide whether they would want to participate. We're also thinking there should be an additional tier of information for those who want it. So again, realising that different people, reasonable people, have different expectations. So having it there just in case, but not having that ultra complex one be the default. We are looking to have more information given verbally. And the key information that it should communicate is that research participation is voluntary, so this isn't an all-in situation, it is voluntary. The aims of the research, and in particular how data would be used differently compared to not being in the research. The extent to which the research alters their care, and what that means also is, because in this situation at least, they're routine standards of care, you don't have to list all of the details of those routine aspects of care in this integrated consent. In fact, the only study-related procedures would be that you'll be randomised between these 2 different treatments, and that your GP might just choose one arbitrarily if you're not in the research. So what we're looking at is, and this may actually come through into other informed consent procedures, is really looking at what the points of difference are of being in the research and being out of the research. And this recognises the fact that, as Marianne alluded to earlier, there are risks in clinical care as well. So what we're trying to avoid is this kind of hyper-awareness of if it's research, it is risky. And we've seen that come through, and it actually dissuades people from participating in research. So I think we're just fine-tuning that a little bit. So one of the big challenges in working through this document is the relationship with ethics and the law. Most societies have legal rules that govern behaviour, but ethical norms tend to be broader and more informal than laws. Although most societies use laws to enforce widely accepted moral standards, and ethical and legal rules use similar concepts, ethics and the law are not the same. An action may be legal but unethical, or illegal but ethical, and we can also use these ethical concepts and principles to criticise, evaluate, propose, or interpret laws. So the role of NEAC is to determine these nationally consistent ethical standards across the health and disability sector, but it also has to comply within the law. So New Zealand law is not very flexible when it comes to informed consent. This requirement created a tension where NEAC wanted to provide ethical guidance, but they didn't want to mislead researchers. So all guidance that has been provided is within the law, but they've signposted aspects that they think there is a legal issue to ethical research. So the 3 most salient examples are research with participants who are unable to provide their own informed consent, opt-out consent, and cluster-controlled trial design, or a general waiver of consent for low-risk research. So NEAC is working with the relevant agencies to follow this through. The HDC released their public consultation results and has made a number of recommendations to the Minister of Health. So we'll be working closely on that to see whether we can get any traction. So informed consent is likely to be one of the biggest biggest opportunities in change that I want to see following the publication of these standards. We want to get out templates on the HDEC side, so you understand what we're expecting and what could be effectively a much more appropriate means of communicating and recruitment. One of the other biggest challenges was health data. This is a long chapter. There's a lot in here. Today I'm just going to talk about reuse of existing data, the waiver of consent for reuse, and looking at an example of proportionality in terms of ethical oversight. So in New Zealand, data is taonga, so it is something sacred, precious, or significant. And a taonga has to be actively cared for in a manner that preserves its integrity and value. All studies use health data. All quality improvement activities use health data. So it's something that we all need to be hyper-vigilant on, particularly in this changing ethics landscape. What we've realised also is that data exists both in analogue, so paper, but also digital. And it's this increasing digitization of data that brings with it the inherent opportunities and risks. Why is that? Well, we used to collect data from traditional sources, so they were collected from patients or from records. We're moving towards novel sources or passive data collection, so apps, fitness trackers, cell phones, your TV. We're really going to see a type of data collection that we've never had to deal with before, so the Internet of Things, and understanding what the consequences are when you link all of that data up together. So, we have a number of challenges with use of health data. Again, health data being used for a lot of research that isn't necessarily health research, that raises a number of risks as well. So we're seeing a lot of good things that we can do, but we have to proceed with caution. One of the things that the NEAC standards recognise, which is a shift if you looked maybe 10 or 15 years ago, is that we're not seeing data be destroyed anymore, and there's a less of an expectation for it to be destroyed. So our health data life cycle very much is about collecting it, using it, storing it, and reusing it. Again, this has to be balanced with respecting people, their privacy and their confidentiality. So this is a challenge, but we have put together a framework in order to particularly consider reuse, but also maintain ethical collection of study data. As I stated before as well, identifiability is becoming less of an effective means of respecting people. So before I kick off on this next section, again, I'll ask researchers in the audience what the biggest challenges are with regards to health data that you're experiencing at the moment. And just one example that we've heard quite strongly is journals requesting more and more data, aggregate data or individual level data. Are there any other examples of challenges, whether it's ethical or practical, around this increased data use?
Information I got from the IT department that data is actually never destroyed anymore within the university because of backups that are stored. And although the primary location can be deleted, backups will never be destroyed. So your data, although you can say data will be deleted after a couple of years, it's impossible to do.
And I think that's the reality, that we went in with the assumption that this data is going to be around forever. We had a number of assumptions going in. One of the others is that assumption that eventually identifiability will be more or less irrelevant. So that's something that's going to be a real challenge. But no, that's correct. We are seeing a real difficulty with both past studies that did say data would be destroyed, and figuring out what whether we need something akin to the future unspecified research consent we get for biobanking for study data, and what that might look like, because we know that data is going to be reused, sent out. It isn't something that really disappears anymore. And the other consideration is that we give tissue so much emphasis, whereas now you can sequence a piece of tissue, it turns into data and then becomes less regulated. So I think, we're really seeing the value of data become, equally important as tissue, which has been recognised in Māori culture the whole time. But in terms of our regulation, we always had stricter requirements on tissue than data. But I think that's shifting as well. Yes. Sorry? Yes. So we've got the Māori data sovereignty principles in our document, but again, having questions of how they're actualised, and that level of control is really challenging, either when the data sets are substantial and you don't want to. I think there's a lot of process that's coming after the fact of some of these new considerations. So I'll go back to the questions. Yeah?
Can I just say I accept we have to accept that data that is stored is likely not to be unidentifiable forever, but I think there still remains some data which is very clearly identified, and that we don't want to lose the protections that we need to have around that, and the question about whether that ought to be destroyed or not, just because of the risk that things that we thought of as de-identified may in future years be traceable. So there is still a distinction that needs to be maintained there in terms of proper handling and what sort of connection it has to people, maybe.
Absolutely, and we haven't thrown the baby out with the bathwater just yet. So we do have the different levels of identifiability, and there will be, utilisation of those as an ethical protection. It's I guess it's one of those looking forward things, particularly as we look at machine learning and just some of the data linking capabilities. I mean, the other thing as well, particularly in New Zealand, is just the inherent identifiability of of many bits of information. Yes, so yeah.
One of the things that we have at our DHB, and I know some of my colleagues at other DHBs have, is that somebody might come for locality approval at ours, and it could be research or it could be quality improvement, but they can actually see data from other areas. So there's regional laboratory results, for instance, or there might be pharmacy data that's available for people beyond the walls of our DHB, so to speak. And what do we do about that? Because we might give locality approval or quality improvement approval, but they can actually access data beyond that.
Yeah, it doesn't sound good.
But it's a reality.
No, the standards in particular do look at the institutional responsibilities around releasing data. We face that difficulty quite a bit at the ethics committee level, because the health agencies, such as the DHBs, are the ones that actually have to make the call under the Health Information Privacy Code. So I take it they're looking, even before or after that approval is given, they can already see it. So that's an institutional problem, and I think that's why we are having that shift from individual researcher, primary responsibility. I mean, that's just not realistic. This notion of the researcher with 50 studies that knows everything that's going on. I think that they're important. It's important to have responsibilities, but institutions are becoming more and more pivotal, particularly in the data context. So I guess it's a good representation of the shift, where that wouldn't necessarily be the researcher's problem. It is a problem, and it's the institution that hasn't set up proper safeguards for access, or part.
The regional lab data has been set up to be able to see it regionally. We're a tertiary centre in the Midland region.
Oh, okay.
So then, when clinicians want to be able to see those results from other areas, it's when a clinician comes to do research that they can also see it.
So they can't partition it in terms of access levels, for example, or something like that.
They might go, "Ooh."
Yes. Yeah. And that's
Or they might be looking at it from a regional view. Is it for us for them to go and get approval from each of the DHBs and then be able to do this?
Well, if the data's coming from different DHBs, we would think that if they. Right. Yeah. Well, sorry.
Can I just make a comment on that?
Yes. Yeah. I think this guy's got the mic.
Isn't there an important principle here related to the fact that if you have an approval, it's a national approval to do research, and that locality approval relates to the specific processes within a particular locality. But if a clinician a researcher has national approval to conduct a research study, and there's informed consent from a participant to access their health information, that applies nationally, not just to the DHB within the walls, because otherwise it would be completely impractical to conduct research.
The one thing just with data, sorry Wayne, the one thing just with data as well is that the health agencies are the ones that have to be responsible for releasing data for research. And so again, ethics absolutely is one thing, and you can have a national approval. If they consent, you're in really safe ground. But if you are looking at, say, accessing databases through a waiver, even though our National Ethics Committee has granted a waiver, the health agency can reject releasing the data on other grounds, because we don't necessarily know at the national level what obligations or consents or whatever sit on that particular data source. So there are different responsible bodies, and under the code, health agencies are primarily responsible.
A key issue, I think, in what we're talking about here in this, maybe I should wait till I go to Thanks a lot. My name is Wayne Miles. I'm sitting on NEAC at the moment and have for the odd year. A key issue in this data use that we're talking about was part of the reason why we as NEAC decided we need to get rid of the notion that there is something quite different than research called health improvement, something called quality, something called observational study, and something called true research. Because actually the data is used by all of those and it's much the same, and it's often used in much the same way. What we were seeing a lot was that people would hide from considering ethics by calling it service improvement or calling it something other than research, and then saying, I don't need ethics consideration. I'd hate to think of the number of people I've screamed at about that. You need ethics consideration of everything, it's just what level you need it at. This is what these guidelines are trying to say. I hope once we're implementing them in the spirit of this issue you're talking about may become less problematic. But I agree in the meantime, those who run the databases need to govern it well. While I've got the mic, the other issue that you didn't talk about when we talk about data use and data as a taonga is the trouble is a whole lot of the taonga is not actually quality greenstone, if I can carry the analogy on. It's rubbish. Mm-hmm. And inherent in us increasing the use and reuse of data is going to be a heavy responsibility on monitoring good data in and knowing the data is good, so that indeed we can then use it in that way.
Wayne's absolutely right, and again it goes to the institutional level of responsibility in terms of that data quality. So this is a huge risk when talking about machine learning, artificial intelligence, as it's only as good as the data that's fed into it. And again, it reflects one of these shifts in focus of the standards where, it's not about a particular application that goes to an ethics committee and make sure that that application is fine. It's looking at the broader research infrastructure. It's looking at institutions because we have to, particularly with data use, data access. These things transcend single research applications. So I think that's the trends that we're seeing. But again, kind of referring to the point before, where we don't want to make research difficult. In fact, the role of ethics is to do, excellent research that achieves its outcomes, that isn't wasteful. Ethics as a barrier, it absolutely can be if it's not done in the right way. And this is one example of where we want to have a proportionate approach to ethical oversight. So, these are example of the Māori data sovereignty assessment questions to figure out how much oversight you might need or whether you should even proceed with the project at all. And this is in fact where we got the idea of turning the principles into questions, because we find that if you can ask these questions about your own study, you kind of elucidate responses that gives you a fair idea about the morality or the ethics of either reusing data or whether you think there might be a few spikes that you might have to deal with a study. So, for example, looking at the sensitivity of the data, how accessible should the data be? How does the use of this data add value to the community from which it came? Will the community support this use of data? How unique is the data? Is the data being used in the same spirit as its original use? Does the user have an existing relationship with the data? Does the user have the expertise and experience to use data in a culturally appropriate manner? Will the data be protected from inappropriate use? And does the institution have the necessary infrastructure to ensure the use of data in a culturally appropriate and ethical manner. So again, it's bringing in the institutions. It's looking at relationships between data holders, data users, and the communities from which they came. So you can imagine, say, a cancer researcher using data from a cancer registry, and it's in a similar or aligned area, relatively low risk. When you're looking at using, using the example that we didn't get to today on the so-called warrior gene, using data from a diabetes study, then reusing it without consent to look at genes and aggression, and the research was of poor quality in the first place, but that reuse is so far from what it was collected for in the first place, and the community would unlikely to support that reuse. That user did not have a relationship with the data, so it just helps researchers sometimes think through their relationship with that data, and that would correspond to some of these considerations here. So, for example, this is the new waiver requirement for both human tissue and data. So it's always been the case that you had to justify to an ethics committee that the nature, degree, and likelihood of possible benefits, including to the participant or individuals, and the value of the research to the public, outweigh the nature, degree, and likelihood of possible harms, including to the participant, individual, other individuals, whānau, hapu, iwi, Māori communities, and any other groups or communities. So that's a weighing exercise for the ethics committee. But in determining whether to grant a waiver of consent, the sections in bold are new. So there always has had to be a scientific, practical, or ethical reason why consent cannot be obtained. So often the scientific justification is used, where you need all of the records in order to answer the study question. Practical, again, looking at the data quality, looking at the way we collect data. Often it's very difficult to go and get consent for these data studies, and the number of records can be massive. Ethical reasons are not so much used, but they can be cases where you might cause undue anxiety when you're investigating some research question using study data, but there actually is necessarily no link between what you're investigating and the data itself. They're very uncommon actually, but what we've added is appropriate data governance plans being in place. So if there are reasons to believe that accessibility to this data should be restricted, we're going to expect that those are in place with a data management plan. We've also added the ability for ethics committees to require that researchers do consult for data use. Now, this is not that common, but we're seeing data use become increasingly complex, and we know from experiences that some of these data use, proposed data use, which have not yet happened, or data use that has happened, actually caused harm to the communities of which the data came. So in some cases, we're going to require consultation, whether that's a cultural group or whether it's a community, perhaps a service that's being received, to make sure that that proposed data use is acceptable. It doesn't necessarily have to be the people of which the data came, but it could be a relevant group, or who might have the interests of the general data use in mind. So again, adding another protection, but only when necessary. Again, when considering a waiver, researchers should identify if there's any known or likely reason to think that they would not have consented. So this is really pulling out the reuse being aligned, preferably, with what it was collected for in the first place, and thinking about what the, putting the person back into the data. So not just treating data as something that's collected and therefore has no value or is value neutral to the person from which it came. And this is really putting data and control of data back into people from which it came. And the second part of this is that a waiver of consent is not a waiver of responsibility. So if you do get a waiver and you find something that is actionable or would be relevant to the person, you have to have that tricky conversation with them where you use their data without consent or their tissue. You found something, and it may be something that's relevant to their life. So really, again, looking at the person at the end of the data. We do it all the time with tissue, but less so with data, and that's a shift, I think, in terms of considerations. This is one of the challenges. I think that we're going to see this happen over the next couple of years, balancing reuse with confidentiality and privacy, and confidentiality and privacy in the age of data linking. So that's going to be something that we'll have to tackle. Health data and new technologies. So when we went out for public consultation, it came back that we have a number of companies in New Zealand working with health data, new technologies, so artificial intelligence, machine learning, and there's a whole host of ethical issues that come with some of these new technologies. So we put together a working group of experts, both lay and non-lay, with regards to health data and artificial intelligence. Really interesting, slightly scary sessions that we had there. And there are many stories about AI and machine learning going wrong. We want to move carefully and slowly. And this is also highly relevant for the fact that our ethical standards cover quality improvement, because a lot of these technologies are being deployed straight into the DHBs, so they're not necessarily coming through the usual channels of health research. They're not familiar with ethics committees. What you have to realise is with the medical community, there's a long history of ethics, research conduct, and obviously with research ethics, a lot of learning that's actually something that's a foundational aspect of being a clinician. However, data scientists and some of these people who are working with data, who are collaborating in the health context, have no history of ethics and kind of understanding of some of these complex relationships. So again, real high chance of misuse, whether intentional or not, and these things can be a bit of a black box. So the chapter and the health data chapter more generally was targeted consult with these experts in the field. One of the things that again goes back to institutions here is that quality of data. So really key to keep that in mind. Now we've put together this framework. Again, it's a life cycle of AI. Some of these new research areas, so medical devices, AI, they really challenge our current paradigm of the way we review research applications, particularly with devices and AI. They're incredibly iterative. They're constantly evaluated. And particularly with AI, there's a number of stages that you develop these kinds of technologies, and we're finding it difficult, and hence why we're reviewing some of our standard operating procedures to deal with the concept of, say, a commercial data company. We always look at commercial clinical trials and commercial, pharmaceuticals, but dealing with commercial data use and using and looking at some of the relationships between DHBs, universities, and private institutions that use data to develop products. These are new kind of novel ethical challenges that we're facing. So again, we've provided a framework for considering the ethics at the different stages of developing an artificial intelligence. A lot of this occurs before it goes live, so before it's actually implemented, and it's about it's effectively developing a tool using patient data. So well worth a read on that one, and it's because they are online only, we're able to update that section as some of the international thinking continues, but very much an emerging ethical area. So now I'm just going to go through a few different aspects of the standards that are key, but I think we've covered this one quite well. Supported decision making is something we've provided a lot of guidance on. Of course, it's going to take some time for this to embed. We want to have templates and procedures that are set out and to utilise, as was described before, with some of the gold standards for Māori consultation, there are gold standards for a lot of aspects of these, maybe aspects of research that are not common throughout a large swath of health research in New Zealand. But we have that expertise in New Zealand, and we are great collaborators. So we're going to talk to some of those experts. I mean, obviously at the Ethics Committee nationally, we have a rich resource of all of these studies and how they're going. So I think we will be able to develop some really good operational guidance for some of these concepts, such as supported decision making. Research benefits and harms. So this one will likely have an impact as well, particularly because it's used to determine how much ethical oversight you need. We have some new categories of benefits and harms. This one in particular is about giving researchers the language sorry, I haven't updated these from, that is pretty much not being able to read. All right, I'll just read this out for you. We've given these tables to researchers so they can look at making a case for their research to show what the benefits are and who those benefits go to, as well as some of the real harm. So for participants, the literature states that the most reported is a feeling of altruism and feeling like they're making a contribution as a benefit. They obviously have opportunities to share experience and greater solidarity. And they also have access to information, knowledge about diagnosis, and access to interventions. So some of this crosses over to communities as well. So access to interventions, acquisition of life skills, an enhanced sense of purpose or an bolstered self-esteem. Community and researcher development. For Māori, development of matauranga, knowledge, understanding and comprehension of the universe. Knowledge advancement for Māori through research outputs, hui and wairanga. And inclusiveness and diversity within the research system. For society, there's obviously knowledge advancement. And for researchers, we have to recognise the benefits of research for them too. Qualifications, status and reputation, mana, and personal advancement and broadened life experiences and skills. Then we have the potential harms. So physical harms, obviously from intervention studies, these harms can be of varying severities or likelihoods. Psychological harms, harms to dignity, social or cultural harms, and privacy or data harms. And in the data chapter, we've provided a whole list of data harms that are real, that impact either the actual people that provided that data or group harms by using that data incorrectly. Sorry, these haven't come through. They're different on my screen. They're a little bit more able to be read. I will cover this anyway because it is important. The standards adopt 4 levels of risk stratification that take into account the type of potential harms individuals will be exposed to, and which are then used to determine whether ethical review is required, and if so, at what level. The risk levels are also relevant when considering the complexity of the study documents, so that includes how detailed a protocol would be, although there are minimum standards for that. Whether modifications to the consent procedures are ethical and reasonable. And in assessing risk, it's important to distinguish between harms that might be caused by research participation itself and harms that are not. So we're really looking at contextualising research risk to be limited to just the research and not looking at the life situation or characteristics of those that are in research and combining those into the research risk. So being more aware of the context in which the research is occurring and not, I guess, being exceptionalist about it, being inherently dangerous to research in these contexts that might already have a lot of risk in them anyway. So it's very much more about being inclusive to research populations. So we have negligible risk, minimal risk, more than minimal risk, and significantly more than minimal risk. So significantly more than minimal risk is research in which there is a probability of an event that is serious, prolonged and or permanent occurring as a result of study participation, or there is significant uncertainty about the nature or likelihood of adverse events. And now what these risk categories also do is, if it is significantly more than minimal risk, it allows committees to put in additional protections in place. So conversely, negligible risk, many quality improvement activities will be negligible risk, but that doesn't mean they have to follow the ethical standards. Distribution of benefits and harm. I wouldn't say this is a new aspect of the standards. There might be an increased focus on that's what happens when you don't write your own slides. It is important to distribute benefits and harms. I'd say there possibly is more guidance in the document, but that's always been a requirement for health research ethics. Right, I have 5 minutes. So I'm just going to go through a few more slides that I have. They get more raggedy as they go, so I was doing them during lunch. But the key thing, I suppose, is that this document is incredibly comprehensive. When I did the talk down in Dunedin before the end of the year, before they were published, I did create slides like this to show all the aspects that each chapter focuses on. It is really hard to pick out which bits and pieces to focus on. But there is so much in there that is the core parts of health research, as well as some of these new aspects. So research, development and design, I have talked about the role of consumers and patients, and I think that's something that we can continue to work on. We have co-design, co-production or participatory research designs outlined. That's brand new in the standards. Also, I'd say there's a stronger focus of research with women and pregnancy, so we have really clear guidance around not excluding women who are pregnant and recognising that as a substantial issue of justice. Ethnicity data collection, recognising the role of addressing inequity through understanding more about who's participating in what research. So this is a constant battle that we have, obviously, with commercial sponsors who won't necessarily do anything with that data, but it's important for us here in New Zealand to know. So a lot of good stuff in there. Here we go. So here's just a few examples of actual standards and how they might represent a bit of a shift in thinking. So this is with regards to research, development, and design, and particularly focusing on inclusion and exclusion of pregnant women. This is effectively recognising that there is a huge gap in terms of data for pregnant women. What we call groups like this are therapeutic orphans. They will be treated in the health system even though they're pregnant. They should be in the research as well. And we're taking that approach to a whole range of different populations that will receive care outside of research. They have to be in the research too. That too hard basket isn't really going to cut it anymore. And there are things you can do to reduce any risks. And this, doesn't go all the other way either, where you involve all pregnant women. It's a considered, fair approach. So I think that's one of the things that was really present when we were developing these standards. And again, it's standards and commentary, so you have the how answered in some cases for you. So again, research and Māori. The chapter on research in Māori really emphasises that maximisation approach for all aspects of all research. So thinking about how studies can contribute to Māori health outcomes in your own context. Considering Māori data sovereignty and the implications for their research, I think that's a challenge that we're going to have to do and are doing more work on, but is of essential importance for New Zealand research. Again, perhaps a change as well as seeing more information and protocols around what the study will do to ensure that the study has an impact for Māori, that Māori benefit at least equally. So some of the things I think that we've talked about in relation to increased cost. These things do cost more. It costs more to oversample. It might cost more to do things a bit differently, but that's what we're going to start seeing at the funding level, and at the ethics committee level we want to see some of that thinking, in terms of different ways of recruiting, for example, feeding into the result of actually having stronger Māori participation. So those are some of the things where the emphasis of the standards are probably shifting to become stronger. Cultural rigour, I went through that one from Barry Smith earlier today. Again, research with Pacific peoples. This represents something where we need to build our capacity. We've had times where we want researchers to engage with Pacific peoples, but we don't necessarily have the infrastructure yet. So the ministry will have to work on this. We'll have to identify those networks and again be cautious not to overburden likely the small group that would be able to meaningfully contribute to some of these difficult questions with regards to Pacific health. But again, it's a direction of focus. It's in the health research strategy, and even if some of these are difficult to meet, we need to build the infrastructure behind it so that it becomes just as much of a norm as consulting with other communities. We've talked a little bit about children as well, so I won't go through that in too much detail. But again, we are seeing an empowerment of children being involved in health research. Again, another example of the vast range of ethical guidance that we provide, so ethical features of studies. Very quickly, I'll go through health systems improvement research. This is going to be one of the biggest challenges, I think, for our ethics committees. Health services research is about implementation, about translation, covering innovative practice as well. So a lot of these pre-formal research activities that occur in hospitals, DHBs, messaging that we need to have ethics as a core part of this entire spectrum of learning, so not just for formal research. Health system research focuses on what needs to be done to improve health system performance, how to influence policy, how to strengthen healthcare systems, and it looks at some of the we call it hardware aspects of financing, information technology, service delivery, health workforce, human resources and governance, as well as norms, values and power relationships, or the software aspects of healthcare systems. So we do expect to see a lot more of this. It does challenge our traditional definitions of what research is or isn't, but it all has to be ethical either way.
Do you include evaluation research under that spectrum? Because often health services, health systems research fits into that, not always a comparator, it's about there is a new way of working.
Yeah, so the standards, they do. So in the quality improvement section, we have different examples of quality improvement activities, and evaluation is in there. So the ethical requirements, particularly outlined in the quality improvement practice, would apply. The categorisation of these things is in NEAC's view on this is that it's less important. What's important is the risks involved in the activity. So the distinctions, some of them are important for regulatory reasons, for publishing reasons, but in terms of ethically conducting activities in a healthcare system, we're seeing those definitions become less important. And it's also about definitions of health becoming broader, healthcare systems becoming broader and leaving the hospital. We're seeing a real dissolution of some of these traditional divides that we've had. And again, quality improvement, hugely challenging to shift gears, I suppose, with regards to how quality improvement is different from research. And one of the real challenges was figuring out changes of standard of care, informed consent, and the relationship between some of the advanced methods we're now rolling out new standards of care and evaluating, what we're doing at different healthcare systems across New Zealand. So I'm pretty sure I'll leave it on that, as I'm just...
I got just a question to tease you out on that a little bit more. So there's a lot of decisions that people in DHBs and other environments make about how they're going to implement services, and I guess this is health services research to a certain extent. But when you want to evaluate something definitively in a clinical context, you like to use a clinical trial to do that. At the moment, my understanding is, and the current guidance suggests it remains so, that utilising cluster designs to try and answer those kind of questions remain impossible without informed consent. Would you like to comment on that?
Sure. So we do believe that there's a legal barrier to some of the cluster randomisation designs that we, on the one hand, encouraging in the health research strategy, but then on the other hand, are not able to approve. The reason is we don't have a general waiver of consent in New Zealand. We have a pathway to provide services for adults who can't consent because of their capacity, and we have waivers for data and we have waivers for tissue, but we don't have a general waiver like other countries have for low risk research or for system level randomisation research. Interestingly, with quality improvement, some of those, say step wedge or a cluster randomised, some of those can occur. It's very complicated in terms of whether a study is research or not, because that's relevant for the Code of Rights. So we're seeing this situation where some formal design for clinical trial research that is utilising cluster randomisation or unit level randomisation, that hits a legal barrier. And what we're seeing is people shifting, what they are calling their projects and their activities to try and circumvent some of those barriers. But what we really want to do is address that actual barrier head on. So NEAC have picked that up. It's on their work program to discuss the fact that we need a clearer environment for researchers to conduct these kinds of research designs, and we think that we think that they're going to become much more common as well.
Thanks for a very interesting talk, Nic. I don't know how many CRAs are in the room, but when you said don't exclude pregnant women, I think we all took a deep breath in, because of course we exclude pregnant women and we're very careful with women of childbearing potential. So how's that going to work for our commercial sponsors?
Yeah, well, it depends absolutely on the phase of the research. It's not to say that excluding pregnant women is never justifiable, but I think that absolutely, particularly for studies that involve treatments, maybe later phase, it's going to be a discussion I think that has to be had. Commercial sponsors are always a challenge with regards to anything in general, but they're a core part of the current system of development of new medicines, and we want New Zealand to have access to those interventions. I think that they will still be able to make scientific and safety justifications, but they should be the only justifications. We don't want blanket exclusions, and part of this is also messaging. So making researchers more comfortable to take on those hard cases. So, we will see how it hits, and we'll see whether they have good enough arguments to exclude pregnant women. If they do, then that is fine. And any other general questions? We are pretty much out of time. Otherwise, I do strongly recommend that you read the standards. Most people haven't. Page by page. Yeah, I heard it takes about 3 days, so take a long weekend. It is. It's a continual development, ethics, and the various relationships that we have. But I am grateful for you all to be here today. I'd like to thank NEAC again in the ministry, and you can always contact us at the Ministry of Health. We're pretty responsive. Thanks. Enjoy your afternoon. Cheers.